Before I start, I think I've been given the easy subject for a molecule which I'm 100% sure everyone sitting in front of me are familiar with this molecule. And many of you may have more experience of using this molecule than me. Before I start, a hands up who's using skikunimab or Cosentyx in his daily practice. Who using it daily practice? Okay. I would assume that almost everyone using this molecule, because I had the luxury of using this molecule since it was launched in UAE in 2015. It was licensed by the FDA in May, June, and then I had my first patients around that time. So this lecture is sponsored by Novartis, but I'm responsible for the medical information. Okay, what we see on the skin is the tip of iceberg. So what we see on the skin as a psoriasis is the tip of iceberg. There is a lot of hidden inflammation within the whole body of patients with psoriasis, not only directly from psoriasis, but because psoriatic patients, they have overexpression of interleukin-17 on almost every organ, in the heart, in the lung, in the brain, in the joint. So what is more troublesome sometimes it is the extracutaneous manifestation of psoriasis than the skin manifestation of psoriasis. We know that psoriatic patients, at least 50% of them, they will have nail involvement, and almost 40% they will have joint involvement, and 50% of them, they may come with acute inflammation, dactylitis or uveitis. And don't forget the nail psoriasis, which is affecting almost 60% of patients, and scalp psoriasis. And despite this nail, scalp, flexures, and genital psoriasis, they are not affecting every patient. They can actually cause a huge impact on the quality of life. Because of the overexpression of interleukin-17 in every organ, you would expect these patients to have a high incidence of arterial hypertension, diabetes, obesity. It's a metabolic syndrome, and ischemic heart disease, inflammatory bowel disease. And no wonder if you have a severe skin psoriasis associated with other extracutaneous skin psoriasis, whether it's on the joints, whether on the flexures area, scalp, your quality of life is severely impacted. So there is at least 80% of impact in quality of life because of your joint involvement, and also because of your skin involvement, especially if you have a palmoplantar inflamed, cracked psoriasis, your mobility will be decreased, and you have a high incidence. No wonder that these patients, they are depressed, and they have a huge psychological burden, and they cannot produce. So their productivity decreases. Those of you who are old enough like me, you may remember years ago, before in early 90s and maybe in 80s, all treatment for psoriasis, they're not targeted. They're not targeted. You treat psoriasis, but what happened when you treat psoriasis with systemic methotrexate, cyclosporin, azathioprine? You treat psoriasis at the same time you cause what you call a pan-immune suppression. So you actually suppress the whole immune system. You may succeed to treat psoriasis, but you're causing a lot of side effects. Since in early 2000, late 90s, we have these new molecules of interleukins, and we now aiming to target the disease with causing less what you call outside effect and side effects. So what is our goal in 2011? What is our goal? The goal, treatment goal, this is in 2010 and 11. Our treatment of goal is to achieve PASI 90 to 75. So the maximum we can achieve at that time is PASI 75. So those who do not achieve PASI 75, we call them intermediate response, and those who did not achieve or don't achieve PASI 50, we call them treatment failure and need to modify the treatment. And this is all depend on what you call on the quality of life, whether they a quality of life more than 5 or less than 5. So what you do when patients do not respond to your treatment, the first and the most important point you need to do is to make sure that your diagnosis is correct. If your diagnosis is correct, you have many options. You either increase the dose, you shorten the duration between the injections, you change the treatment or you add topical treatment. These all options. These goals have increased since 2019, and now we defined anyone who is less than PASI score 75 is inadequate response. So we aim for 90 and plus. We aim for absolute PASI of 3 or less, and we aim for the DLQI of 5 or less. So if anyone who do not achieve these figures, we consider them as treatment failure. You need to think about your treatment. Those of you are old enough, as I said to you, you remember before 2004, we had this all systemic treatment, including methotrexate. The best we can achieve is PASI 50. And then TNF alpha came in the early 2000s, and now we become what you call happy that something, new molecules came in. We aiming for PASI score 75. In the 90s, we have the interleukin 12 and 23. We started aiming for 90, but now we want 100. Patients don't want complete clearance of their psoriasis. Patients do not accept that you treat them partially. So patients, they come to your clinic, they want clearance, 100% PASI. That means absolute count less than 1. So what you need to do, you need something which works fast and work quicker. So if you compare Cosentyx or secukinumab to INT'L, there is 50% improvement as early as week 3. So 50% improvement as early as week 3, and 80% improvement in the PASI score as early as week 16 compared to Stelara. And this improvement is sustainable. That's what you need. You need something which work and work and work, and you don't want the patient to lose control. You don't want the secondary failure or primary failure. Luckily enough that every biological we have now, there is almost zero primary failure. If you see a patient with psoriasis and you give him a biological treatment and the patient do not respond, your treatment is not right. You need to reconsider your treatment. You may be treating cutaneous T-cell lymphoma, you're not treating psoriasis. All of them, they, as I said, rarely you get secondary failure, but primary failure. But secondary failure can happen. Luckily, because of the very low immunogenicity, the secondary failure in secukinumab is extremely low. So those who achieve PASI score 75, 90, or 100, almost 100% of them, they still having the same, what you call, PASI score at year 5. We want something which work for extracutaneous psoriasis. We want something to work for the nail, work for the scalp, work for the genital area, because these are the most difficult areas to treat in psoriasis, and these are the most troublesome one. Imagine someone had a severe nail psoriasis. Even without skin psoriasis, their quality of life is severely impaired. So from the baseline, at week 16, there is at least 40% improvement compared to placebo, and it's 73% improvement compared to placebo. You need to understand that treating nail psoriasis is completely different to treating cutaneous skin psoriasis. Patients has to be more patients. They're already patients, but you need to tell them you need to wait for years and 2 years and maybe 5 years, because the improvement is consistent, and the more the patient continuing with treatment. Exactly the same with palmoplantar psoriasis. They slow to respond, but they do respond eventually. You get about almost 60% improvement in 2.5 years compared to placebo. Scalp psoriasis is almost the same. The improvement could start as early as week 12 and goes on to week 24. And you need something which work for skin and work for joint, because majority of patients you see with the skin psoriasis, they have some joint involvement, either psoriatic arthropathy or entitis or dactylitis, where they are very painful and they can be very troublesome. It is, I think, in acute inflammation of entitis and dactylitis, there is at least 80% improvement as early as year 2, and this improvement is consistent to year 4 and 5 to about 70 to 80%. Also, you need something which work for the joint. I need to tell you that although in dermatology we are a bit lucky that we can make psoriasis go. That means you can get PASI 100% absolute PASI 1. In rheumatologists, they are slightly less fortunate because they aim for ACR 60%, or this is the best they can do, and that's can achieved in week 12. So at least 63% of patients, there is improvement in ACR and spondylitis compared to the placebo treatment. So what happens if you make patients better? So if you make them better, they have improved what you call problems with mobility. So they can walk, they can functioning, they can get out of the bed. So the morning stiffness gets better. They can reach to what they want. They can wear clothes. They can shower. They can button and unbutton their clothes. They can go to work. They can perform their daily activity. And understandably that if you make them better, if you improve their psoriasis, if you improve their skin psoriasis, psoriatic arthropathy, you improve their quality of life. So as early as week 4, 20% of patients of psoriasis, they have improved quality of life, and this goes on by year 1 and by year 5. So by year 5, almost more than 90% of patients with psoriasis, they have improved quality of life. So it doesn't matter where the IL-17 comes from. Does it come directly or comes through the track of IL-23? It all goes to blocking the IL-17, and it's independent of its score of source. This is usually a slide for medical students, but I think to remind you, those of you who are old enough like me, you remember walking to the dermatology department there with about maybe 20, 15 beds. You smell of the tar, and it can be very, what you call, the smell can be intolerable. Then we have topical steroid, topical vitamin D, and they mix them with steroid. But these one now, hardly ever they are used, and you can only use them in very limited psoriasis when you need to, what you call, to jump to second-line treatment. Either you go to the old-fashioned second-line treatment or the biological we are available. So what does the international guidelines say about Cosentyx? NICE guideline. Those of you who worked in UK, you know what NICE guidelines stand for, National Institute of Clinical Excellence. These guidelines are cost-effective guidelines, so they're based on the effectiveness and the cost. So because NHS in UK is a free service, the NHS has to make sure that they need to spend the right amount of money on a medicine before they can approve it. So it is cost-effective. And what they say, that they say Cosentyx is recommended for treatment of adult plaque psoriasis with severe disease, PASI more than 10 and DLQI more than 10, who failed. This is what the NICE say, because the NICE is slightly different. You have to fail to systemic treatment, either methotrexate, phototherapy, and also, not only that, the company has to give them a special price. That's what in UK. And they treat, and then they define what treatment failure. Treatment failure or adequate response. What's adequate response? 75 reduction in the PASI score. 75 reduction in the PASI reduction in the PASI score from the baseline, or 50% reduction in PASI score plus 5-point reduction in DLQI. This is what's called adequate treatment. If patients don't achieve this treatment in week 12, you have to stop the treatment. The same with the British Association of Dermatologists, which is just like a society of, but it's not a governing, doesn't have a power, but they can advise the government. They have the same recommendation. But the American is slightly more liberal because the medicine is available. So the American, the FDA said the secukinumab is recommended as monotherapy for moderate to severe plaque psoriasis, strength of recommendation A. So the same is for psoriatic arthritis, the same for what you call palmoplantar, and for severe what you call plaque psoriasis. So the indication is here, you can use it as de novo. You don't need to have a secondary line treatment. So what does the UAE said? Okay, I think some of you may be in this list of treatment, and this list of they say they just echoed the guidelines of the Americans. They recommended as monotherapy in adult with severe psoriasis. What you need to do before, even though there is no evidence that IL-17 will activate latent TB, but you still to do it. You need to do a TB test, depend on your country, depend on the regulations. We do quantiform TB test. You need to make sure that the patient has been vaccinated up to date, routine hematological tests, and skin screening. So this is just a summary of what is available and what you do, what category. If you are pregnant, you can take biological category B, but they're not actually primarily indicated. But if patients are on IL-17, you need to reassure them as long as they stop the medication before the 3rd trimester, and as long as the child, when they're born, they don't have live vaccination for 6 months. Okay, and if you have elevated liver function test, obviously you cannot have acitretin, you cannot have methotrexate. The same apply for pregnancy. And if you see here the biological, especially IL-17, they are almost safe for every patient, and they are more effective than they are more effective than other medications when it comes to efficacy and the side effect profile. So the beauty about IL-17, there is less risk, no increased risk of TB, no monitoring for TB after treatment, no contraindication in patients with myelinatic disease, heart disease, and there is very low increased risk of infection and no impact of there is no drug-to-drug interaction. So it is relatively, I think they are very, very safe and very easy to use. Side effect, as you know, IL-17 can cause pharyngitis, rarely cause candidiasis. There is 2 cases of ulcerative colitis in this one, and one of them is a reactivation. But in general, they are extremely and very safe. The same thing with severe side effect, they're relatively safe. And inflammatory bowel disease, as I said, Crohn's disease, there is no case report of Crohn's disease, 2 cases of ulcerative colitis. The injection is very easy. It comes as 150 milligram. There are 300 milligram, and there are 75 milligram, but we don't have it in this country. I have a huge experience with this medicine. I have about 45 patients who take this medicine, not only for psoriasis, but I give them for hidradenitis suppurativa and for other indications. I'm not going to talk about hidradenitis suppurativa. Most of my patients are either de novo, they've never been on other medications, or they have been on other medications, including biological treatment. I have only, out of 45, have only 1 patient who actually secondary failure. So the majority have been and sustained on the treatment. Let us take a few cases. So this is a professional gentleman who actually very highly professional gentleman, but he has a problem that he cannot actually meet people. He cannot actually shake hands. He walked with a stick when he came to my clinic. So he came to see me initially in 2019 with very painful, cracked, severe, classical palmoplantar psoriasis with demarcation here, and he tried all topical treatment, including emollients, steroid. He's a smoker, he's hypertensive, and had a family history of psoriasis. And if you see on the examination, you see this classical psoriatic palmoplantar plaque psoriasis. So initially, we continued on topical steroid plus what you call salicylic acid. We start from apremilast, but unfortunately, after 1 month, he couldn't continue the treatment, stopped because of the gastroenteritis. So we gave him the classical regime of Cosentyx. So 5 weeks later, he's pain-free. You can see the improvement yourself. He's very pleased with himself. He's socially engaged. The first time he came to see me without the gloves, and he can walk without stick, and he bought me an iPhone mobile. Sorry, I shouldn't say that. Okay, so he remained on treatment. I saw him last week. He's still actually almost PASI score 1 and D requires 0, and he will not stop the medicine. This patient said to me, I'm going to take a picture with Cosentyx. So he came in 2006, severe psoriasis. He tried phototherapy, nitigisone, methotrexate. As you see, he had a very severe psoriasis, PASI 43, D requires 17, BSA 60. And he has some evidence of psoriatic arthropathy. We start him on the regime of the and this is in November later, he was much better, pain-free, PASI score went down to 14. There's 75% PASI improvement, and he's continued to improve in May 2019. He kept well, and his PASI score now is 2 with DLQI2, and BSA is 2. So as you know that Cosentyx is given 300 milligram weekly for 5 weeks, then 300 milligram monthly. There are new doses. Regime came in for people who weight over 90 kilograms. You can give them what you call double the dose, but they're still not licensed. We have doses for children. The medicine is licensed from age 6, and you have to be 50 kilograms or above. The only problem. So this data is actually old data, 5 years. We have almost 250,000 patients taking this medicine for the last 5 years, but I think the number is higher. You need something which works fast, which is consistent with less side effect and no immunogenicity, so you don't lose effect. So I think I have finished here, and I finished exactly on time. This is actually an oasis in the center of my desert of my country, Libya. So you wonder where this water comes from, but this is not artificial. This is real. So if you want to visit, you can visit this area. This is a picture from Libya. Thank you.